We are live. Mic test, mic test. Okay. Mic test. Mic test. There we are. All right. Good evening, members, or afternoon. Today is December 14th, 2022, and it is 4:03 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. Public communication. We will receive public communication for both the Executive Committee and the Board of Managers meeting before we proceed to the Executive Committee meeting agenda. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yersinia, did anyone register to make comments for either the Executive Committee meeting or the Board of Managers meeting?
Yes, Chair Bell. There are 4 people who wish to speak for public comment, but 2 cannot speak until 5 p.m.
That sounds good. We will break from our agenda and allow those 2 individuals who need to speak at 5, and then we'll go ahead and take the other 2 now.
Okay, perfect. I will now read the guidelines for this meeting's public communication. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a further meeting. We received 4 submissions for public comment, 2 via our online portal, 2 via voicemail. 2 speakers will be speaking at this time. I will call on our first speaker, Mr. Frank Ortega.
Is Mr. Ortega with us via virtually or here in person? I don't see him in the room.
I don't either. I'll call on our second speaker, Manager Valadez.
Manager Valadez?
Thank you. Thank you all for being here today. And happy holidays. My name is Cynthia Valadez. I'm a manager of the Central Health Board of Managers and have been on this board since 2015. It was Sendero that was originally created in 2011, primarily to use as an HMO, as a platform to channel members to using community care and other providers to build up the Medicaid patients and align Central Health sponsored healthcare providers. Initially, Sendero Medicaid was hamstrung because Central Health, at the creation of Sendero, had negotiated high in-hospital rates that made Sendero Medicaid financially unfeasible. It was Wes Dukowski, the CEO of Sendero, who later renegotiated those in-hospital rates to get Sendero on firmer footing. It was CEO Wes Dukowski who made Sendero financially feasible because he was able to figure out a business and health model to move high acuity MAP patients to capture federal risk adjustment monies with over $30 million coming back to healthcare needs with a leverage of 1 to 3 or more that translated into $1 in and $3 back to Sendero. It was Wes who put Sendero on a better footing, financial footing, and a little bit more than a break-even basis with Partnership for Central Health. I want to take this opportunity to thank Central Health for even having created Sendero. and having it as an alternative or as a vehicle that we can use to provide healthcare services and access to healthcare for our patients, our high needs patients under the CHAP program, and as a continuation, as an alternative or another option for affordable care insurance services. I want to also thank Wes for his service to our community. He will be missed, and we hope that his modeling of community involvement and sponsorship of community practices and benefits services to the different organizations that we provided assistance to and furthered our Central Health name and our Sendero program, that will be continued. I also want to take this opportunity to thank the Central Health Board and Mike and our Central Health staff for having supported Sendero and Wes throughout his tenure here. And for me, a personal thank you to Wes Dukowski for the work and his commitment to our community, to Central Health, and to Travis County and surrounding counties who are also participating in Sendero health insurance programming. Thank you very much. Con mucho le agradecemos. We thank him and wish him well. We wish him well in his future life, next journey of his life. Thank you.
Thank you, Manager Valadez. I think I see Mr. Ortega. If you would take the stand, please. Sorry, I didn't mean to take your job away from you. Yersinia.
Oh, no, you're good. Thank you.
Okay. Thank you.
Thank you.
Good afternoon, board members. Thank you. My name is Frank Ortega. I registered as Francisco. That's my given name. I am the past immediate District 7 LULAC. I have a resolution here I'd like to read out loud. You have a copy in front of you. It's pretty long, so if I get to the time where I have to cut off, I'll finish off with the therefore. Resolutions to recognize Wesley Dorsesky, President and CEO, Sendero Health Plans, Inc. Whereas in 2021, it has been 10 years since Sendero Health Plans, Inc. was certified to facilitate more access and affordable health care for the poor through a nonprofit community-based health maintenance organization. Whereas Wesley Dorsesky, President of Sendero's Health Plans, assumed the position at a time Sendero was fledgling and under development. Therefore, Mr. Dorsesky and his staff has over time achieved remarkable success in creating the highest rated marketplace in Texas with low co-payments for primary care providers, visits with no pre-existing conditions. Whereas Senderos is committed to finding new and better ways to serve the Central Texas population, and as the only community-based nonprofit by developing community partnerships and use of community health workers to identify, target, and effectively address the greatest healthcare needs in our community. Whereas Mr. Dorsesky conceptually and implemented a partnership between the Medical Access Program and Central Health Access Program to meet the needs of community members in great need medical care with particular acute medical conditions. Whereas CHAP Sendero members can access Sendero's large network of primary care and specific specialty doctors to address their medical conditions quickly and effectively, with the added benefit of enabling Senderos to be eligible for payment from the Affordable Care Act risk management programs. And for Plan 2021, Sendero received a payment of $32.6 million from the risk management program. Whereas CHIP is very highly regarded by the program participations, and CHIP Sendero members give the program high marks in Sendero surveys with a satisfaction rate of 96.8%. Whereas the financial support from Central Health, Sendero is partnership with the Health Alliance for Austin Musicians, expanded enrollment to over 400 musicians on a Sendero Silver plan in 2021 and improved the lives of the area musicians. Whereas in 2021, Senderos achieved a Best Place to Work award from the Austin American Statesman. Whereas on September 18th, 2018, the Central Health Board of Managers voted to begin to dissolve Senderos, offering thousands of enrollees. Whereas on September 26, 2018, Central Health Board rescinded their previous vote to cut Senderos health plans, offer the community and Sendero members voice their support for Sendero and how they depend on the coverage to obtain medication and live healthy lives.
30 seconds
Whereas
remaining.
after 10 years, Mr. Dorsesky has led Sendero Health Plans to successfully prove Sendero's value and worth to continue and expand upon its service, offering especially the CHIP Sendero program that Travis County residents need and deserves a definitive expansion and support from Central Health. Therefore, be it resolved that Mr. Wesley Dorsesky and the Sendero team has recognized for building Sendero Health Plans as a successful working model for Travis County in improving the health of its members through innovative programs and strategies for our community most in need of affordable, accessible, and high-quality insurance. Signed by Frank Ortega, LULAC District 7, immediate past director. Thank you.
Thank you, Mr. Ortega, and thank you for that resolution. So, Yersinia, is that the end for now?
Yes, for now.
And then I'll keep track of the time, and hopefully somebody can remind me if I lose track. At 5 o'clock, we'll stop and have the other two individuals provide their comments.
Perfect. Thank you.
Thank you, Yersinia. And I'd like to thank all of the presenters for their comments. We will now proceed to the Executive Committee agenda. Agenda item number 1, approve the minutes of the Central Health Executive Committee meeting November 16th, 2022. Manager Brinson.
I vote to approve the Executive Board of Managers meeting from November the 7th, 2022.
November the 16th,
November the 16th, sorry.
2022 meeting. Manager Valadez.
Second motion.
I have a motion from Manager Brinson. I have a second from Manager Valadez. Any further discussion? Hearing none, all in favor? Aye. Any opposed? Any abstaining? Minutes are approved. Agenda item number 2, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. Brianna Yanis will be presenting.
Okay, I'll start by going through the January agendas, tentative schedules. So for Strategic Planning Committee on January 18th, we currently have minutes and then a healthcare equity operational implementation and financial sustainability update. And then we will receive a year-end update on communications, community engagement, and community outreach. And then tentatively a CHIP update. For budget and finance, that will also occur on January 18th. And we will have minutes and the fiscal year 22 audit. For executive committee on January 25th, we will have minutes, tentative schedules, the CEO evaluation tool for fiscal year 23, and then CUC board appointments, interviews, and then consider the reappointment of Dr. Tom Coopwood. And I'll pass it off to Mike for a brief comment.
Yes, and also for the January 25th Executive Committee meeting under tentative schedules, what we'll bring back to the Executive Committee is a reporting schedule that tracks the budget resolution, and that's the outward-facing resolution that says this is how we're going to invest the dollars for this fiscal year. And so there are a number of items in that budget resolution. And so what we'll do at that Executive Committee meeting is bring that schedule forward, most likely running them through the Strategic Planning Committee meeting, as we always have, subject to the call and agenda approvals of the chair, and anticipate that those reports coming in February and then again in April and July. But we'll, certainly we may take some interim times in there if we look like the agendas are starting to stack up. If we wanted to come back and give you that forecast or preview of budget resolution report outs. Thank you.
Okay, and I will move on to the January 25th Board of Managers meeting. We'll have minutes, investments, financials, and then a placeholder for Sendero business items and the reappointment of Dr. Tom Coopwood to the CUC board and the appointment of the second CUC board member. We will approve the fiscal year 22 audit. We will announce appointments to Central Health Board committees. We'll have a CEO evaluation tool for fiscal year 23, legislative priorities, a UT Dell Medical School review of reporting matrix, and then tentatively close out DSRIP. And that is all I have on the tentative schedules.
Okay, any questions or comments with regard to the tentative agendas on the January meeting? Hearing none. Anything else from?
We also
Yeah.
have a memo behind that same agenda item regarding the community care board appointment process timeline. We're putting out an open call for nominees to be submitted by January 5th to Perla or Mike. And then on January 25th at the executive committee, members will interview the nominees. And then at that board meeting, they will recommend it to the full board.
Manager Valadez.
Brianna, can you tell me, or Mike, can you tell me whether or not that slot that additional slot that they need to fill on the community care board, is that a community member, or is that someone that is a participant in MAP program? Because they have two different.
Yes, correct. That would be a community member at large.
At large, okay.
Manager Musaitu.
Thank you. A quick question. I'm not sure if I remember, is there a term limit for the community care board? Is it in the bylaws or anywhere?
I don't recall if there is
Is it 2 years? Or
consecutive term limit.
Okay, any other questions? Just want to remind the board there's going to be back-to-back meetings on January the 18th, Strategic Planning and then Budget and Finance Committee. And then, of course, our Executive Committee and Board of Managers meeting will be on the January 25th. Just wanted to call your attention of the two meetings on January 18th. And Manager Valadez?
Do we know, or have we been, have we received any kind of notification from the Travis County Commissioners as to when the first joint committee meeting will be?
Mike, did you want to speak to that?
Yes, I can address that. Perla's had some conversations with the judge's office, and right now, we've obviously been told it's not going to be December. We are needing to actually circle back around with the county to discuss actually having it in a workshop setting versus being an item on the agenda, if you will, so that way we can have more open and robust discussions is what the commissioner have asked for. But those conversations still need to take place. But as of now, we do not have a tentative schedule for the workshops.
Okay.
Thank you.
All right. Any other questions? Okay, hearing none, I will call up agenda item number, wrong agenda. Agenda item number 3, discuss and take appropriate action on the appointment of 2 members to the governing board of Sendero Health Plans. And we will be going into executive session. for this particular item. And so I will read the announcement and then we'll allow about a 5-minute recess so that we can get set up for the interviews in the closed session. So I announce that the committee is convening in closed session to discuss agenda item number 3 under Texas Government Code Section 551.074, personnel matters. And it is December the 14th, 4:24 p.m. And so we will recess Okay. We are now out of closed session. It is December 14th, 5:52 p.m. Prior to entertaining a motion, we had two individuals who wanted to speak in public communication, and I'd like to call them up now. See if I remember their names. Let's see.
Hi, Chair.
Rachel Blair and Paul Scott. Yeah, there you are, Lieutenant. Go ahead.
Yes, I believe they are both online. So first up, I will call Rachel Blair.
There she is.
I'm sorry. Thanks. Just a technology thing there with the mute. I wanted to introduce myself for those of you who haven't met me yet. My name is Rachel Blair. I am the Chief Operating Officer at the Health Alliance for Austin Musicians and have worked with many of you for years on our premium assistance program that we collaborate on together and some other initiatives. And I just wanted to take a moment to thank each of you for your continued support for our partnership between HAM and Central Health and the investment that Central Health makes in our community really is truly critical and life-saving. I have the best job in the world in that I get to hear the impact stories from the low-income Travis County residents that we serve together. Recently, many of you heard James Bookert speak at the Travis County Commissioners Court in favor of Central Health's budget. He's one of the HAM musicians that participates in the Central Health Premium Assistance Program. He outlined the personal health struggles that he has had over many years and the incredible impact that this funding has made for him. He has a severe, has been a part of the Central Health Premium Assistance Program. 2023 will be his fourth year. He is going into 2023 with a $0 deductible coverage for the life-saving prescriptions that he needs and an out-of-pocket expenses capped at $1,300. So it's just amazing. As his career is taking off, this is the bedrock of safety and support that he draws on to be able to go out across the country and do what he does best. Since the beginning of our working together, Central Health has funded thousands of plans for musicians like James, providing comprehensive coverage. And for people who really truly would be uninsured otherwise, to show or talk briefly kind of about the collective impact that this funding creates. The premium assistance dollars that y'all invest in this program draws down well over $6 million in federal tax credits with a combined impact of over $9 million. That's just in 2022 alone. What that means is that not only are real live human beings and their family members covered, and that money is also invested in the local healthcare infrastructure and the local healthcare system, providing providers with good payments for amazing work provided. I want to mention too, just in, since it's been a minute since we've had a chance to have a conversation, that HAM is continuing to do our work on equity and inclusion, and that is really manifesting in very meaningful impacts and connections throughout our community, namely getting more musicians of color and female identifying musicians enrolled in these plans, and the with health outcomes. We are working with a musician right now who was uninsured. His life was in danger. He was admitted to the hospital, had a quadruple bypass, and will be covered by this program starting on December 1st. That's the difference that this program really makes. I have reported outcomes around equity and inclusion in past presentations, and will continue to do that after this fall's open enrollment wraps up. We are very encouraged by the progress, but we are wholeheartedly committing to ongoing work in this area. And I really want to acknowledge the incredible opportunity to enhance these efforts, made in part, made possible really in full actually by the CHIF grant funding that we received. We're launching a new program called Amped for Better Health, and we cannot wait to talk to you more about what we discover as this program unfolds, and are just extremely grateful. And just wanted to
30
close
seconds.
by, thank you. Just wanted to close by saying thank you for your consideration for the agenda item tonight that would impact an additional 400 musicians and their families. And just, you know, from a strategic high level, it makes a difference in the system. And then on a human level, it makes all the difference in the world to people like James and to people like this dear musician who just had bypass surgery. So I appreciate your time very much, and thank you.
Thank you very much, Rachel.
Thank you, Rachel. Up next, we have Paul Scott.
Yes, thank you so much for the opportunity to speak tonight. Rachel and I are tag teaming from HAM. I'm Paul Scott. I'm the CEO of HAM. And I too kind of want to say, I've been with HAM for a little over a year now, during which time it's been quite evident about how important the Central Health Premium Assistance Program is to our working musicians in Austin, and what that has meant for our low-income musicians to secure health care and to mitigate more serious health issues because they're able to access preventative services in particular. I know as Central Health continues to strategically focus on the needs of low-income and disproportionately impacted individuals and families in Central Texas, we also at HAM are committed to reaching out to our Austin musicians of color to expand access to healthcare. And as Rachel mentioned, you know, we're really focusing on kind of the equitable access to healthcare as part of our outreach throughout Travis County. Central Health's Premium Assistance Program, you know, helps over 1,000 low-income HAM musicians annually, and we greatly appreciate your commitment to our musicians. I know that this evening as well, y'all are considering an additional allocation to the Premium Assistance Program to help more low-income musicians. We appreciate the strategic focus to help provide more healthcare access, and we are happy to commit our staffing and infrastructure resources to assure our musician members have access to those healthcare services. We support them through our eligibility process and help them navigate through their healthcare services as well. So thank you for what you're doing and for your consideration and for focusing on efforts to help keep live music in Austin. So thank you.
Thank you very much, Paul. We appreciate those comments. Okay, members, there is a motion needed on agenda item number 3, discuss and take appropriate action on the appointment of 2 members to the governing board of Sendero Health Plans. Manager Valadez?
I move that the executive committee recommend that the board appoint both Gerald McDonald and Molly Hahn to the Sendero Health Plans Board of Directors.
Manager Brinson?
I second the motion.
I have a motion from Manager Valadez. I have a second from Manager Brinson. Any further discussion? Hearing none. All in favor? Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Okay, members. Agenda item number 4, and just for the public's knowledge, this item will be on the agenda for the board meeting that's coming up right after this meeting. It will be a consent agenda item. It was our recommendation to the full board, and if that consent agenda passes, it is complete. Agenda item number 4, confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health executive committee meeting is tentatively scheduled for Wednesday, January 25th, 2023 at 5 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. I recognize Dr. Brinson for a motion for adjournment,
I move that we adjourn.
and I recognize Manager Valadez for a second.
My second.
There's been a motion by Manager Brinson, a second by Manager Valadez. Any further discussion? Hearing none, we are adjourned. Thank you, members. We will go, in the interest of time, directly into our Board of Managers meeting. And today is still December 14th, 2022, and it is 6:02 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. First item of business will be consent agenda. Consent agenda C1. Approve the minutes of the Central Health Board of Managers November 16, 2022 meeting. Consent agenda C2. Receive the quarterly investment report and ratify Central Health investments for November 2022. C3. Receive quarterly financial and operational reports from Community Care Health Centers and Sendero Health Plans. C4, approve the Sendero Board of Directors appointments as recommended by the Executive Committee. And C5, receive a written update on the Cooperative Purchasing Organization memberships and approve resolution to join 791 Purchasing Cooperative. I'd like to accept a motion. Manager Valadez?
I move that the board approve consent agenda items C1 through C5.
Manager Brinson?
I second.
I have a motion from Manager Valadez. I have a second from Manager Brinson. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Members, we will now proceed to the regular agenda. At this time, I will entertain a motion to limit debate on all items in the regular agenda for our meeting this evening. I would limit debate on all items on the agenda to 3 minutes per member per item. Do I have a motion? Manager Brinson?
I move the Board of Managers limit debate on all items on the agenda to 3 minutes per member per item.
Second.
I have a motion from Manager Brinson. I have a second from Manager Valadez. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Members, there are some adjustments to the regular agenda. Item number 5 will not be heard this evening. That item is our standing real estate item. Agenda item number 5, discuss Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health, and enterprise partners and new developments in eastern Travis County. We will also be moving agenda item 3 to the end of the agenda, and there will be an open session presentations on items 4 and 6 before we go into closed session on items 4, 6, and 7. Finally, the open session presentation for item 6 by Community Care will be right after agenda item number 1. Agenda item number 1, accept nominations and elect a board manager for the position of treasurer to fill the unexpired term which began January 1st, 2022 and will end December 31st, 2023. Members, at the previous meeting, I was accepting nominations or at least wanting to hear from anyone interested in becoming treasurer. I do have a member who is willing to accept the position of treasurer and fill the vacancy that's left by Manager Zuniga. So I would like to nominate Manager Moram Musaitu for the position of treasurer.
To second that nomination.
Thank you. I'm told by David that we do, unless we have another nomination, we do not need to vote on the nomination, but we will vote on the election. Correct? Yes. Manager Valadez.
I'd like to move that we adopt the name of Maramu Satif as treasurer to the Central Health Board by acclamation.
There's a motion on the table. Is there a second?
I second.
I have a motion from Manager Valadez. I have a second from Manager Brinson. All in favor?
Aye.
Aye. Any opposed? Motion carries. Congratulations, Manager Youssef.
Thank you, appreciate it. Thanks, everyone.
Agenda item number 6, receive and discuss updates on the 1115 Medicaid waiver, delivery system reform, incentive payments, DSRIP program, and associated projects, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas, and the University of Texas at Austin. Tara Trower, Chief Strategy Officer from Community Care, will be presenting. And Jason, sorry.
No, it's all good.
I know. I'm very excited to be here.
Yeah, very much.
This one's on. Green means on. Yes?
Yes. Thanks, Mike. Well, good evening, Board of Managers. Thank you so much for having us this evening. I believe this is the first time our not so new, but new mostly to you folks, that Community Care's Chief Strategy Officer, Tara Trower, will be assisting me this evening in presenting. And she's actually going to do the heavy lift. So it's our distinct privilege tonight to come following a budget recommendation and approval by the board to support the Black Men's Health Clinic here in Austin. And we'll be presenting tonight in terms of the recommendations around what that agreement looks like. We were asked to come back by December, and it's December, to present how that relationship would be put forth and to gain your buy-in to what the deliverables are as it relates to that. So I'm going to without further ado, hand it over to Ms. Trower to go ahead and present. So Tara, please.
Thank you so much, Jason, and thank you, Board of Managers, for allowing me the privilege of addressing you all in person today. After a long, seeing many of your faces virtually, it's very good to be here and have a dialogue about this very important initiative that we are going, hopefully, participating in a much greater way. Before I go into the outreach plan, I did want to just sort of lay the landscape for you in terms of some of the challenges that are faced in the fight for equity for men of color in particular. Travis County is not much different than the rest of the country in terms of the fact that Black men in particular, but men of color, access healthcare at a lesser degree than many of their counterparts. National studies suggest that Black men are 75% less likely to have health insurance than white men. Men generally are 24% less likely than women to visit the doctor in the past year and are 32% more likely to be hospitalized. That's the national landscape. And then for Black men, as we look even more closely at that subpopulation, the rate of death by stroke between the ages of 45 and 54 is 3 times higher than their white counterparts. The risk of prostate cancer is much higher, to the tune of 74%. And 2 out of 5 have high blood pressure that starts at a younger age than the rest of the population. The reasons are varied. I think many of us, having been in the healthcare sector, are very well aware that there is a lack of trust for a variety of reasons, including a history of racism and under representation within the healthcare delivery system, a lack of insurance. Preventative care is not prioritized by men in general for a variety of reasons. There is a real fear of clinicians that have been documented, as well as perceptions and immigration status. When you look at the research, one of the things that sort of compounds the situation is that feeling uncomfortable or having fear or mistrust often leads to a lack of compliance even when the men show up for their appointments. And so it really creates a cycle that even if we cross the hurdle around initial access and making sure that there are locations and providers close to them, they are more likely to have conditions, whether it's diabetes or hypertension, that are not under control because of that lack of utilization of the healthcare system. Next slide, please. So when you look at community care and men of color, community care has treated in 2021 more than 12,000 African American patients. And that's the equivalent of 11.6% of the Travis County African American population. Our overall population, as many of you may be aware, our patient population is largely individuals of color. So about 75% are African American and Latino. When you add other individuals of color to that, we start to get upwards of about 80%. These are individuals who are largely under 200% of FPL. And so when we really look at this very vulnerable population, it is truly the underserved. When you break that out by gender, for African Americans, you can see on the slide presentation, it does bear out that women are overrepresented in the patient population, both for Black African American patients as well as for our Latino patients. And in fact, the gap on the Latino side is much larger in terms of percentages. And so we really do, when we look at men and how they are utilizing the system here in Travis County, there is definitely a gap that we are continually looking at ways to address. Next slide. So this here is a pulled report from the American Community Survey from the US Census, which just gives you an idea of sort of the breakdown for the African American population in particular as it pertains to Black men. Overall, the total male population is about 50,000. And then when you take out those under the age of 18, we're really talking about an overall population of 39,000 or so. As you all know, the numbers don't tell the whole story because back to the original slide, the population tends to be underinsured at a higher rate. They tend to be unsheltered at a much higher rate. But the small size and dispersion means that interventions are even harder to direct to the populations that need them most. Particularly, and we'll look in a bit at where those individuals live. And so I just wanted to say, the Latino population is much larger, without a doubt. But when you look at this population, designing interventions that really kind of get at the population to close the gap on equity really requires some creativity and forethought, and as we will talk about later, actual boots on the ground in terms of doing that outreach. Next slide. So when you look at Travis County, and I know that you guys have heard Jason speak before about the real gap in terms of lifespan expectancy here in Travis County, a difference of about 10 years, depending on which side of the interstate you're in. What we did here was pull out from the 2020 census the cohorts. How many men are they really are, starting at the age of 55 to 64. If things were truly equitable, you would see those share of the pies stay pretty much steady, even though obviously the number of individuals at 65 plus and then the number of individuals at 85 plus, there is definitely a fall off in terms of numbers for a variety of reasons. And so when you look for that 55 to 64% Latinos and African American males make up, that's approximately 19-20% of the share of males. When you get to those getting to 65 and over, you see the dramatic shrinkage of that share of the pie. And even though this is not an apples to apples comparison, this is not tracking the same cohort of men across time, which I think is the way a lot of the folks in the medical and scientific community would prefer that we do it. It is very suggestive of what happens in terms of the longevity of the male population and the inequities that exist based on race within our community. And then probably even more shocking, at least to me when I looked at the numbers, is our population of 85 plus. I honestly thought that it was a typo, that in 2020, there were only 138 African-American men in the county with a population of 1.3 million now, that's where we're at. Similarly for Latinos, it's 770. And so I just share this with you to indicate that, when we're talking about chronic conditions, we are talking about the ability to live a long and healthy life, and the numbers here in Travis County do in fact bear that out. And so when you split that out in terms of the ratios of men to females for each group, for Latinos, even though there is definitely still inequities, the split between men and women within the Latino population is closer to that of their white counterparts. But for African Americans, there's approximately 6 males for every 10 females in the same cohort. Next slide. So when we look at where our African American population lives, male population lives in Travis County, to no surprise, there has been sort of a shift in the traditional neighborhoods that we like to think. I've been in Austin area by and large since 1988, and so I've certainly been witness to the changing demographic shifts. And so when you look at the more densely populated areas, and what you see there, the darker represents a higher percentage. It is definitely north and northeast, although certainly there are pockets and dispersed populations across the county, including further to the south, and then still some density within more traditional areas. So next slide, I'm going to shift a little bit from where we are in Travis County to bring you guys along a little bit on the timeline of the relationship between the Black Men's Health Clinic and community care. And I know that a few months ago, there was a presentation about the work that has been occurring at the BMHC, but I wanted to define for you guys a little bit more what our collaborations to date have looked like over time. So as you all know, the Black Men's Health Clinic was founded with the goal of providing integrated services in a culturally competent, culturally sensitive environment to really build a safe place, trusted care with health care providers and teams that could really address some of these unique needs, as well as some of these unique challenges within the population, not just for African American men, but for men of color. The initial steering committee included representatives from across the community, including representation from the St. David's Foundation, the Austin Independent School District, a number of longtime community partners, including the African American Youth Harvest Foundation, and has since acquired status as a 501c3 nonprofit. Community care, Jason and I began speaking with the founders about a potential partnership in the fall of 2021. Separately, in collaboration with our board as we were developing our strategic plan, the Community Care Board did identify increasing the number of African American patients as a strategic goal. One of the real key points there is that one of the emphasis is actual numbers and not just percentages, because the numbers are small, and we really wanted to judge not just as a share of the population, but whether or not we were able to increase real actual numbers of African American patients who were treated. Additional groups that are part of that strategic plan, just for your awareness, includes Asian Americans, the pediatric population, and that population between the ages of 18 and 26, that young adult population who may not believe that they need healthcare, but that early introduction really sets them on the right road and path. And so those goals were embedded in our strategic plan, which was adopted last January, almost a year ago. Next slide. So the Blacklands Health Clinic, which is located on 290, very much sort of on the edge of that segment that you all saw on the map that I showed you, where the African American population is still most densely populated. They opened in March of 2022, and they are currently providing services by a number of partners. We are not the only one. So there are screenings being offered by the American Heart Association, the Sickle Cell Association. They have some collaborative work happening with the School of Nursing at the University of Texas, as well as with the Dell Medical School. They also have bilingual mental health service providers, TX Cross, which I believe is still providing behavioral health support and services on the weekend. And they do currently have HIV screening through the AIDS Healthcare Foundation. The board of directors, as we continue to sort of develop and see what this relationship might look like, approved our CEO, Jason Fournier, to add the BMHC to our HRSA scope. As you guys may be aware that as an FQHC, we do have to get approval from HRSA when we stand up both mobile and permanent sites, and we were confident enough in the degree of need and how it fits strategically with what we are charged to do at Community Care as an FQHC, Community Health Center partner with Central Health, that was something we wanted to do, acknowledging that we would ramp up as numbers dictated as we were able to bring patients in. So we began delivering care on site in July using our mobile care framework, which is a little bit different than what we use for our permanent site. That's the street team, part of the Healthcare for the Homeless team that makes sort of regular rounds on any given day to stand up care. Initially at the BMHC, we looked at 2 evenings a week, thinking that those later hours for care would provide greater access for this target population. We were able to go ahead and start care in July, and BMHC was officially added to our HRSA scope of service in October. CUC does already have an MOU in place to cover our clinical services and responsibilities. That is something that we do with all of our mobile sites that we are in regularly, and it spells out the responsibilities of the entity who is housing us and that we are using their facilities, as well as what our obligations are and responsibilities are as a healthcare provider. As we move to the outreach plan that I'm going to cover in just a moment, there will need to be a second to cover that community outreach work, and those are separate and apart from each other. The one that currently exists is very similar to the others that we currently have with the Austin Transition Center. Thank you for a second. Sunrise Church and a number of other places that are part of our rotation where we offer mobile services. Next slide. So this is where we are in terms of our clinical services only. The patient numbers are small, but we're growing. As you can see from the chart, we did move the clinic from evening 2 days a week to a full day session on Tuesday after we got feedback from patients who said actually really what they wanted was a appointment during the regular daytime hours. The folks in the BMHC leadership have started their own marketing outreach campaign, running videos and commercials, for example, at the Maynard Football Stadium and other places, using creative ways to get the word out in terms of not just the community care services that are available there, but the other partners. But it does include elements of CUC. We are actively recruiting for a permanent clinical team for the site. Right now, we're using overtime and borrowing from sort of our current pool to make sure that it's staffed that 1 day a week, but we are recruiting for a permanent team to really build that continuity and the relationship that is part of the model of the Black Men's Health Clinic, and continue to provide that high-touch continuity, safe space. Although I will say that the team that is currently there is very vested in the effort, and so they are seeing the same faces most weeks when they come in. Our goal is to increase the number of days as demand increases. We have also dedicated a CHW to help reach out to existing male patients, and this is, to my mind, one of the really exciting aspects of this particular partnership. You know, you saw the number up there that we have 12,000 African American patients that we serve at Community Care in 2021. Not all of those are consistently in care. And looking into the data, what we have seen is that particularly for some of our male patients, we are realizing that they have hypertension needs or other issues when they come in for convenient care services, because very often folks only come to their doctor when they're really, really hurt or they need a doctor's note, not for the preventative care and really the healthcare home that we want to take a look at. And so we're taking a look at those patients, reaching out to them to let them know that if they're not consistently in care at one of our sort of traditional brick and mortar locations, that this may be an option for them if they are interested in doing so. And so as you can see here, the numbers are increasing. I did ask the team what things looked like this past Tuesday. And so we did see, we had 10 appointments, 8 folks showed up, 4 of which were Latino. 1 was African American, 1 was Anglo, 1 was non-responsive, and 1 mixed race individual. The ages ranged between 19 and 54. When you talk to our CHWs in terms of the feedback, they say that the team anecdotally feels like the population that they are seeing is actually more vulnerable in many ways than the populations that they are used to seeing in our other clinics. And so they are really trying to be cognizant of some of the needs around that, particularly around transportation, given the location that it's at, and giving more grace than we already do if things are missing or things are not quite where they need to be in order to facilitate the visit. And they did convey one story. Our community health worker has been going to basketball games to do outreach and screening. And we had one patient who came in for a checkup, and it happened to be a few days before the job fair that we had, and they were able to refer him to the job fair, and he did show up. And so it is part of the mission, and part of having that community health worker is to refer folks to the other things that they need, not necessarily become our employees, but I think you get the idea that we're really trying to be holistic about how we look at the service that are provided and really treat the whole patient. Next slide. So current challenges and some of these you did hear already, so I won't go through them all. Unlike some of our other clinical startups, that there is not a pre-existing patient pool or prospect list, that there are churches and other folks, which means that this work is really high touch in terms of letting folks know what's out there. Of course, there's social media, of course, there's media campaigns, but those are not always the things that drive people in to actually see a provider. As I mentioned before, this is a difficult population to reach, particularly because of its relatively small size and issues of mistrust. We are still working on having a permanent staff, and our current site does have some limitations. Our partners have worked really hard to bring in water and make sure that we have adequate exam tables and that there is space that meets our clinical requirements for HRSA. But it is not a full practice like at some of our other sites that have lab facilities and other things, but it is an important link so that we are able to link folks if they do need to access those additional services to the other site that may be closest to where they live. One of the things that really stands out is that because of the unique nature of the site and the number of partners that are in the site, that we really do need to have more coordination between community care and the other partners, particularly regarding outreach activities. Many events conflict with the other community care outreach resources that are busy working on various other projects within our other 27 health centers. And it has been proven that the events are much more successful when a navigator or community health worker with a template read at hand is able to schedule patients directly, either for financial screening or directly for an appointment. Which brings us then to the next slide, which is what we're really here to talk about, which is the Men of Color Outreach Plan. And so in the box are the elements that are part of the contract with the money that would be allocated, that we would, community care would contract with the Black Men's Health Clinic to hire the following staff, 2 community health navigators, community health workers, 2 community outreach ambassadors, which are more similar to sort of traditional community outreach workers, and then a community outreach program manager, which will guide the team, coordinate many of the activities, be that point person to make sure that time, place, and all those things are accounted for, and also, frankly, to help track and collect some KPIs so that we know how many contacts are being made, whether or not we're converting those individuals to patients, to make sure that we're reaching the target population that we really hope to serve, and also serve as that point of contact and coordinator between community care, the BMHC, and the other partners and events at that site. So it's really looking holistically and providing some of that umbrella to make sure that we're not stepping on each other's toes, and to make sure that when folks reach out, if they interact with one organization, that they get them where they need to do, particularly on the actual Medicare healthcare front. And with that outreach, doing that high-touch coordination, inclusive of for the healthcare, for the health navigators, that while they would not have complete access to our EHR, they would have the ability to schedule appointments through something called Epic Link. We also anticipate having them access findhelp.org, which is a really robust referral system to really help facilitate getting them to those other non-medical drivers of health or SDOH needs that this population also needs to access. The Black Men's Health Clinic will provide the equipment, criminal background checks, and as well as I mentioned before, those demographic data on a monthly basis so that we can keep apprised of their work. Outreach activities, local businesses, churches, schools, community events. They've already started some work with athletic leagues and other places that specifically target men of color and underserved communities. I can't underline that point enough, although this initiative is about meeting some really specific needs within the Black men's population. There is understanding and recognition that this is holistic and that this is reaching out to all men of color, but really all men are welcome. We have even had one female patient in the clinic. We're not turning anyone away. The team will also dispatch health navigators to locations to schedule medical appointments as needed, make referrals to other relevant partners. We're also asking them to help recruit individuals for a focus group to further define the focus for the initiative going forward. The birth of this is not the traditional way that we do things, but we want to make sure that we're not making assumptions about what men of color need. And that focus group would be inclusive not just of African American men, but also Latino, hopefully Asian American men, to really get a full picture of the types of services on the health front that are required and what's really standing in their way from their perspective for accessing care in Travis County. Personnel costs we pay to establish hourly rates that are identified in the MOU based on the qualifications of staff. The staff will be employees of the Black Men's Health Clinic, but they will receive training from community care teams, particularly around privacy, the limited use that they will have of our EHR and our other protocols and safety procedures and those sorts of things, because they will be in our clinics. Just a few more slides and then I'll be able to get to your questions. Next slide. And I think that you all got these early. This is just sort of a list, as I've mentioned before, of the data that will be reported on a monthly basis, and we will pass this information along to the central health staff so that they will have visibility into it as well. That really, from our perspective, is helping to build program infrastructure and building that client-patient roster to support primary care expansion when it is time to do so, making sure that we're connecting individuals to care, whether or not it can be completely facilitated within the Black Men's Health Clinic, but if we need to get them to a clinical pharmacist or nutritional education or some other things, to really be that entry point for service for a more activated healthcare management experience. And then developing the data set to evaluate proof of concept for future funders and for Central Health. We want to be able to prove that this is worth the investment that you all are making and working towards sustainability on a multiple fronts. And so next slide, and I'll go through the timeline really quickly. So our hope is that with the support and finalizing some details with the Central Health staff and the concurrence of the Board of Managers, that we would be able to execute the second MOU that I mentioned earlier that would cover the positions and the pay schedules and some of the other specifications around the requirements for this team. The Black Men's Health Clinic is poised to recruit and hire employees or contractors who will go through onboarding by Community Care. We hope to be prepared to do so, hopefully by the end of January, at which time we will start receiving the monthly updates as described. In June, Community Care will provide a written update to Central Health staff summarizing those activities in total to allow time and consideration to determine next steps. I will say that since we're nearly done with the first quarter, although I believe the money that was initially envisioned really contemplated a full year of work. And I know that there are limitations with regards to how money is allocated across years, and that's something that we will need to talk about and discuss. And just sort of making clear that we are committed to the provision of primary care at this site. And so even though up there, in terms of what happens with the community outreach efforts, an evaluation will need to be done as to whether or not that will continue. But it is our intent that as the need continues to persist, that this is a population that we are quite committed to serving. And so with that, that concludes my presentation to you about our intent for the funds, and I'm happy to entertain any questions you might have.
And I think one thing that I would, thanks so much, Tara, such an excellent job. I think hopefully the context of what's being proposed aligns with what the Board of Managers was contemplating when you decided to make this investment in building capacity around trying to increase access for men of color within Travis County. And it's something that we at Community Care feel very strongly about as it relates to health equity. I think it's an investment. While we've been caring for folks, this is a very targeted intervention that has a lot of potential, especially to get to men who've either been lost from care or have not engaged in care for some time. One example would be is we took a look at our diabetic patients, and specifically our African-American patients, and we looked at those that were out of control, and we noted that over 700 men were out of control, of which about 430 had not actually been in for regular care within our system. So because of, to Tara's point earlier, because we operate walk-in convenient care, they're not coming in necessarily for ongoing care. When they're feeling very sick, as Tara indicated, they'll engage, but they'll only engage at that point. And we try to follow up, but there's a lot of demand for services. So by having increased capacity to engage them in the community and then to help men regardless of their race, ethnicity, engage in care, but in particular men of color, is critically important if we're going to narrow that health and equity gap that has persisted in our community that leads to less life lived for our men of color. So we really thank the partnership we've had with the Black Men's Health Clinic and at least standing up some additional services, but also your support of trying to create greater health equity within the community at large for all of our men, but in particular the men of color. So as Tara said, she's ready to answer any questions you may have.
Okay, thank you, first of all, Tara, Jason. That was an excellent presentation. Lots of really interesting and I would say information that I was not aware of with regard to the African American population in this area. So thank you for that. I appreciate it. I know that Manager Musaitif and Matwani have already raised their hands and Melodez, but I would like to start with Manager Jones, who is joining us virtually. Manager Jones?
Thanks very much for the opportunity to have the presentation. And I must say, in my 23 years here in Austin, in the public health arena, as well as in the healthcare arena here, Tara, your presentation really hit home very well in terms of the numbers. And I think we fail to look at that. So I want to compliment you on your presentation and talk about it. I think the initiative that you've put forth is a great beginning point to address these issues. One of the data that we collect in public health is to look at mortality and morbidity rates. And a lot of the numbers that you've indicated result because we as a community have not invested in health care for this population. Where we've had populations of service for everyone else, African-American men particularly, and men of color specifically, do not approach health as others. And so this initiative, which will be unique, not only here in Austin, but also in Texas and in certain places around the country, I think is a unique model to begin to address the disparity we see in the deaths and mortality of Black men. So I'd like to thank you for that. I guess a couple of quick questions and then I'll let my colleagues go. One is, your geographical distribution was very unique in showing where that population is. So intervention efforts at getting there should be a little easier, even though I'm not saying that they will be easier, to be able to have targeted outreach intervention efforts in those communities, particularly North and East Austin and Travis County. Do you have under your outreach plan strategies to mobilize not only those who are 65 and older, but those who are 18 to 65, efforts to get at those populations particularly to address those? And then the second part of the question is, are you going to be looking at sort of the getting young Black men and young men of color who are coming out of high school who are in sports mobilized around health and fitness so that they can be models to go forth as well? You could do that through partnering with public health or other agencies, but have you looked at those as well?
So one of the strengths of this partnership, as it has been envisioned, is that under the direction of the folks at the Black Men's Health Clinic, that they have a much closer relationship to the community and already have a high degree of credibility within the African American community within Travis County. And they are already actively making inroads, to your point, with those groups. And so some of the other activities that will be draws include men's groups. It includes outreach to churches. It includes, I think, as I mentioned, they have initiative around being present within some of the basketball leagues, which is a way to really connect with some of the younger members in the community. And so they are, and we have really, from what we have heard, we believe that they have the capacity to look at those things combined with the data that we are able to pull down in terms of where folks live, down to the census tract level, working with the folks at ECHO, because while that map represents the housed population, it does not represent the unsheltered population. And so there's also ongoing discussion with them how to reach out to that subpopulation of men of color. I think one of the things that has certainly happened in my experience in this area is that we like to talk about demographic groups as being very homogenous. And to your point, the needs of men of color who are 65 plus are very, very different from those who are younger and what their needs are. And so I think that with this effort and investment, we are better positioned to hit a number of those key areas to really make the most of this outreach effort and hopefully see the results within the clinic itself.
Well, I just want to commend you all for working with the leadership at the Black Men's Health Clinic has done a phenomenal job with very little resources to be able to be where they are. So I'd like to commend you all support and working with them. I think that's a natural partnership. And I think that you can go a long ways in beginning to address those disparities that you've identified and has been identified for many years. So thanks so very much. And I was hope this board will continue to support those efforts.
Thank you, Manager Bill. I mean, sorry.
Manager Jones.
Manager Jones. It's late. I didn't have dinner.
I did give her coffee.
I have coffee, yes.
You have to.
Thank you. Manager Motwani?
The presentation was fantastic. I think it validated a lot of our hopes about what could occur. I certainly applaud leadership at the Black Men's Health Clinic and Manager Jones for helping, I think, snap us to grid and galvanize us as a board around the importance of the community need and this investment. The presentation was brilliant. I really appreciated, of course, the shallow dive into the numbers, as well as early insights and how quickly you've operationalized them. You know, things like moving from 2 days into finding the need on which day it needed to be available, or at least addressing that need appropriately and operationalizing it. I love the nimble way that that's been done. And the thoroughness of that plan, the outreach plan and the hiring plan with CHWs down to how that looks with using the EHR, in a way that really represents some thorough planning. And I'm really bullish on it. Numbers are small and they are growing, and that's exciting. And so in the startup world that I used to be in, people talk about bootstrapping things. It's almost the best kind of enterprise an investor could want to look at, because they can incrementally see, wow, well, they've really pulled that together. This opens the door for future investments, and that's really my hope, is that this model that we're seeing and how you all are taking it to fruition opens the door for much more appropriately sized investments. So thank you all.
Thank you, Manager Motwani. Manager Musaiti?
Well, thank you for that presentation. Appreciate it. I see opportunities and I see gaps. So I'm going to highlight a couple of things that I think that central community care should really focus on. I think the numbers are striking and that they're really alarming. Now, in terms of the age group, and I concur with Manager Jones, we also need to address the younger group, but now just focusing on the older population and giving the high the incidence of mortality for this group. We want to prevent that. Now, has community care wanted to stratify what are the comorbidities amongst this population that you can address? And this Black Men's Clinic can really facilitate addressing services that to modify these comorbidities. I do not know what's the main cause, what's killing them. I'm sorry, using this term. what is the main cause of their deaths? And we want to prevent it. So I think that would be very critical to address what is the problem that we have. I understand trust, but in addition, the social drivers of health and the comorbidities exacerbate, the mortality rates amongst this population. Now, another concern that I had, the limitation, why, if they're going to provide a health navigator that will have limited access to the EHR, that is a limitation. They cannot address and understand what are the composition of this individual, what are their medical history. So I'm concerned, why couldn't this navigator be a nurse navigator that can connect, that can identify the high needs patients who needs immediate services and provide those lists? Because you mentioned one of the gaps is you don't have a list, but you can easily develop a list from these patients that really needs the attention and the immediate care that your partnership can help and assist with. So in addition to that, the high percentage of the no-shows and the cancellation, that's significant combined before 45% of the population that you already have, served. What are you tackling? I know you want to address, the hire of the community health workers, but if we're not being able to manage these 45%, how can we take on a higher pool of patients? So these are missed opportunities, and I am not, I'm just trying, looking at it in terms of care coordination, missed opportunities, gaps, and how can we refine to ultimately improve the health outcomes of this critical need population. And another thing, there needs to be, I understand one size does not fit all, and I know that this is a clinic for all men of color, but every specific men's of color has a specific needs, and their outreach is different. So I know this is probably, I'm looking at it as a pilot project in my mind as a researcher, so I'm like, okay, why can't the focus be on one group, and let's do a great job to address and bring those individuals to care and improve their outcomes, rather than trying to stretch ourselves too thin because of the limitation of the staff that you currently have. So I can go there a lot because, this is the space that I really hope that we can improve, because the data really is striking, and we need to think about our younger population. How can we tackle them? I think unfortunately African Americans, we know, are high rates of incarceration. We need to work with the jail system, with ease transition, to really look at modifiable factors that we can overall improve their survival rate, and not just tackle them at the point that it's really hard to really improve. But we have an opportunity, and from this male group that you have identified at least 964 patients, maybe you can create a list that can help and ease. And I'm hoping that one of the individuals who you hire is a nurse navigator who has complete access to the EHR, not limited access, because that will hinder their progress. Thank you.
Yeah, I think, yeah. Please.
Yeah, yes.
With respect to focusing on one population of the larger men of color population, part of the wording behind the budget resolution was to reflect what was happening at the Men of Color Clinic, or now the Black Men's Clinic, but still, that's looking at the broader population. And so part of the reason why there may not be a specific focus really is a function of the budget resolution and us trying to support, the larger vision for the Men of Color Clinic. So that's something that I would need to own up to, but I'll hand it off.
I think your points are very well taken. So I think kind of backing up to the beginning of your questions, Manager Lisa, is when we take a look at stratification for our patient population, we understand. We know the comorbidities for the folks that are in our care within our electronic medical record system, and we know it by age, gender, race, ethnicity, and we've got a pretty good understanding of that. Lots of opportunities, because there's still a lot of opportunity to create greater health equity. But when we take a look at the purpose of the resolution was in conjunction with the Black Men's Health Clinic, was about engaging individuals who either weren't in care or have been lost to care, as well as strengthening resources around individuals who are in care but maybe use it less frequently. So when we look at one of the biggest drivers to why there's such a discrepancy or disparity as it relates to health outcomes inclusive of longevity for our men of color, a lot of it's about the fact that to Tara's presentation, our men of color are underinsured or uninsured at a much greater rate. And we know that there's two biggest predictors, regardless of where someone lives in the United States, is whether or not you're in poverty and whether or not you've achieved greater than a high school education. Those two factors are predictive. And our men of color suffer from poverty at a much higher rate than anyone else, both women and Caucasians. And then educational attainment is much lower. And so those factors in and of itself are predictive. Coupled to that, then is, again, to some of the things in the presentation, is the trust or mistrust in utilizing systems and the availability of those systems and overcoming generational segregation, racism, and structural things that have really gone ahead and made it very difficult for men of color in particular to engage in healthcare on a regular basis. You're spot on, and so spot on in terms of trying to also not just look at a single cohort, but coupled to that is not lose sight of the fact that we have younger individuals for which there's a trajectory we can help change. We've got to address the ongoing health concerns and the burden of disease within the existing population, the older population, and that's a heavy lift. And engagement through outreach and understanding what are your health needs, what's accessible to you, and how you can access it's critically important. But at the same time, and what's not been shared in the presentation, our adult population skews more female, and a lot of that has to do with prenatal reproductive health. But when we take a look at our overall pediatric population of Travis County residents, it skews actually higher for males than it is females. So the 52,000 or so pediatric patients we're serving each year, there's an opportunity to learn through this and also engage those individuals from a generational perspective into their health and to help drive outcomes for their fathers, their brothers, whomever it may be, and also engage the families at large. So I think, again, your points are very well taken. This is an evolving project for us, and we're certainly going to learn and appreciate the input and feedback that you have for us here at the Board of Managers as we continue to partner with the BMHC to go ahead and try to effectuate greater health equity for our men of color. Tara, did you have something you wanted to add?
I did. So I have a slight researcher's brain also, and it really is my hope that as we build this out, that we will get to sort of critical mass so that we have some numbers and some actionable data to work from. Because right now we're guessing, and as you saw, part of the goal was to do the focus group and to actually talk to folks. So we're not guessing. Because although I am African-American, I am an African-American with insurance, and I don't know what's standing in the way. I can make some guesses because I have a brother and I have a father, but they're not even the target population that we're really trying to serve. And so getting us to some real numbers so that we can start to make probably not conclusions, but to really guide the work so that we can iterate to the point of, it being like a startup. Where do we need to focus? Where do we need to pivot? Where can we do the most good with the resources we have? And so I do hope that we get there. Also, I agree with you.
And one of the things we failed to answer for you is our outreach folks have limited access through Epic Care Link, but they can see a lot. And the documentation is a little bit more limited.
But they can't complete a chart review.
They shouldn't. They don't have the clinical expertise to do that. But we have the one thing that we failed to point out is, well, these are outreach folks that are out in the community, very similar to what we do with some of our CHWs and outreach workers already within the community. There's a care coordination, care management team that's assigned to this project as well, but that's on the direct delivery side. So you're not seeing that complete picture in terms of the clinical assets that are being deployed.
But in order for them to provide those services, they need that access to link them to care. And so do you see the gap where I'm envisioning?
There's coordination that happens there. We didn't do as an effective job of demonstrating that. So we'll make sure.
That's really the concern that I have. I'm like, okay, they have limited access to EHR. There is a significant, like this 964, patients that could be stratified on high priorities that can link them to the care they need. So that's the
So-
issue that
Manager Masaki,
sorry,
I'm sorry to interrupt.
I apologize, but I'm
We
just
are
trying.
over our limit, number one. Number two is, if you could meet with Jason and Tara after this or sometime via
make out my
phone
point.
and, discuss this point, if there's any further discussion needed. And so but I do appreciate the dialogue. I think it's beneficial to the project itself. And, I think you guys can sort of get there based on what we're doing currently and what have a vision of doing in the future.
And always happy to meet, and we did get your point. Thank you.
Thank you very much. Manager Valadez.
You all have confirmed what we have already known for decades and for generations. Okay, as someone whose parents and grandparents were in the trenches fighting for the inequities that existed in the systems of care, the educational system, the healthcare system, blah, blah, blah. This is exactly what we need for Travis County and our Black community. However, that doesn't necessarily speak to the needs, as we all acknowledge, are different for our different populations. In the Latino population, especially Latino males, who aren't going to get to your clinics because they're working 7 days a week. And if they're off on Sunday, they're on the soccer fields, they're not on the basketball courts. Okay, totally different way of reaching them, totally different set of issues. And if you know that both of you know the numbers, you know with the changing demographics, we're the vast majority of people who don't have insurance, okay, who are not accessing care. And so I'm at a point, and I have been, and Mike knows this for at least 3 years, of saying, well, our Latino population needs the same resources and the same targeted focus on getting the data so that we can develop those research-based strategies to stop the cycle of death, which it is death, okay? And all I have to do is sit there and look at what happened during the main part, those 2 horrible years of COVID, when we're 50% of the death, 50. And a lot of that, I truly believe, is language barriers. Aside from economic, but it's definitely language barriers. So when you're hiring staff that speaks English, and you have to rely on telephone for interpretation services, it's not going to work. That's not going to cut it. Okay, it's not. That's why I and most of the people I think on this board are advocates of making sure that from the bottom up, from the top down, we have staff in place, providers in place that can speak the language, have that lived experience of the population that we're trying to reach. Less than 200% FPL, non-English speaking. Immigrant, no, not necessarily full legal status. They may have matriculas, they may have their permanent resident card, but that still excludes them from having a lot of systemic resources. So we need to get going on the brown side. But for what I advocated for is what I'm very glad that you are here giving us good news and solidifying and proving that yes, this system didn't get it before, but this system here at Central Health is working with community care and even through Sendero and integral care, because that, don't get me started on mental health and behavioral health issues, as they push you out in elementary school to alternative because you hit somebody in the first grade, and that sets the whole trajectory. So I want to thank you all for the work that you're doing, continue to doing. I'm going to support you 100%, but we need your support to also look at what the majority of the population that we are serving in Sendero at Central Health is not necessarily getting to, and that's that focused strategic plan and focused resource, I guess, system development for the non-English speaking population. And it's non-English speaking. I think that's the problem right there.
I think that's well stated, Manager Valdez. I think we are, since we transitioned to Epic, our 2021 Uniform Data System report as
Right.
reported to the Health Resources Service Administration demonstrated 39.6% of our patient population is best served in a language other than English. Fast forward, our fiscal year, similar to yours, ended at the end of September.
Mm-hmm.
That number now, because we've got better data capture, it's up to 56.3%. So it's significantly, so the concerns that you and your peers are sharing relative to linguistic competence and sensitivity and cultural awareness, we share with you. And we are doing our very best with our partners at Central Health to try to go ahead and position ourselves to best serve all the populations within Travis County that are low income, underinsured and uninsured. And I commit to you as the CEO for CommuniCare, we're working very deliberately with our partners. We have HR Share.
Yeah, this
I
is
think you're aware
enterprise.
of that, and it's synergistic, and we appreciate Mike's support and all the great work and direction that you're providing to him and through and to us as well.
Well, I appreciate it,
Thank you.
Tara. Thank you very much. But I'm going to be getting back with you along with a whole slew of other people to work on developing that non-English speaking component.
Thank you very much, Manager
Okay,
Valdez.
and I want to thank you and congratulate you on the work you're doing, getting started.
Thank you. Manager Jones, I haven't been watching the screen. Did I see your hand up? If it was, and you do need to make a comment, we're close to time here. Everybody's pretty much used up their time. So if we could have it short, that'd be great.
Thank you. I'll make it very short. I would encourage you to look at the historical perspective. There's been a lot of work done here on health and recommendations through APH. And I would encourage you in terms of looking at some strategies and recommendations for this population. This is not new, as Manager Valadez said. This has been a problem for years. It's been known for years, and people have been trying to address it. So I commend you on the efforts to do that. I think the Black Men's Health Clinic will be a model for those efforts, not only here, but across the nation. And I just want to say this, and I respect all of my colleagues, but the reason we're here today is because for so many years, these same issues were present. The data was there, the knowledge was there, but we, for whatever reason, decided not to address the issue.
Right.
So I hope we don't use this as a missed opportunity. I think this Black Men's Health Clinic is a great opportunity to begin to address the least of those among us in terms of mortality and morbidity. So once again, thanks very much. And like Manager Valadez, I'll be willing to work with you all as I have been with Black Men's Health Clinic and their leadership in making this a reality for this community.
Thank you, Manager Jones. Appreciate that.
Amen.
Thank you, Jason. Thank you, Tara. Great conversation, great information, and we look forward to working with you to continue to refine. All right? Thank you.
Appreciate the support as always.
Thank you
so
very
much,
much.
Board of Managers.
Okay. Before I bring up agenda item number 2, I do want to introduce our newest board member, Dr. Manuel Martin, who is here observing, but we look forward to you joining us at the table very soon. Thank you very much. Great. Oh, she's virtual. I'd also like to introduce and welcome Councilwoman Ann Kitchen, and we really look forward to you joining us as a group and your input from all of your experience. And thank you for attending tonight's meeting and observing.
I'm excited. I know that Dr. Martin and I both are eager to get started. Thank you.
We look forward to it. Thank you.
Congratulations.
Okay, agenda item number 2, receive an update on Central Health's ongoing equity-based systems planning work and operational and financial sustainability planning, which will include discussion and gathering input on developing plans to implement the board-adopted healthcare equity plan. Monica Crawley will be presenting with Dr. Abhi Sharma and Danielle Srinivasan and Julie Clark from Guidehouse.
Sorry.
Okay, so thank you, Dr. Bell, Monica Crowley, Central Health, and Board of Managers. And tonight, we have Dr. Abhi Sharma from Guidehouse, who has presented to you guys before, and Danielle Srinivasan, who also has presented to you guys many times before. We are going to do something a little different than we have done since I've been at Central Health. We've handed out clickers to all of you that have your name on the back of them. The clicker has been identified with you for Open Meetings Act purposes, but we are going to, after a short presentation by Dr. Sharma and Danielle, we are going to gather feedback from you and help facilitate a discussion and tee up conversation for discussion and to receive your input that Dr. Sharma and Danielle are going to guide you through, but using the clickers. So I think this is going to be something that should be fun and informative and allow you guys to provide feedback. Manager Jones, we can't do the clicker over the internet. However, after each question, there's going to be an opportunity for discussion of the topics that Dr. Sharma and Danielle are going to guide you through. So, thank you.
Thank you. So, like Monica mentioned, my name is Abhi, and I'm a director with Guidehouse. Okay. So, good evening, everybody. My name is Abhi, and I'm a director with the strategy practice at Guidehouse, and I'm also a practicing physician based in Houston. I've done a lot of work with the federal healthcare systems that are managed by the state, as well as local healthcare systems at the county level, specifically safety net systems in Dallas, as well as in Houston. And I've been working with the Central Health team for almost the last 12 to 15 months. And what we wanted to share with you today are a couple of things. So the first one is we want to make sure that we walk you through the journey of how we got to where we are when we think about the work that we undertook. We want to share some key findings from our work, and we also want to chart the course for what is going to come next. Towards the end, like Monica mentioned, we have an interactive discussion lined up where we would love to hear your thoughts on specific areas that we are looking at. And towards the end, we are going to reserve some time for questions and an open discussion. So next slide, please. So when we began this journey, we as Central Health wanted to make sure that our patients get the care that they deserve. And right at the center of that was the idea of a high functioning system of care. What you see on your screen right now is a graphic that lists the different components of a high functioning system of care. Now, the question that you might have is, why is this the high functioning system of care and not something else? So this is the crux of what we've seen across the country. So when we think about safety net systems that are efficient, that meet the needs of the community, they are typically structured in this way. So if I can bring your attention to the purple cog in the center, this is the core of the system and includes the infrastructure that makes a system work. The two things that you would see here are services, which are non-clinical in nature. So think about navigation, concierge, scheduling, eligibility, as well as the infrastructure that is needed, right? So IT infrastructure, physical infrastructure, personnel. Now this cog in the center makes the other cogs function. So when you think about the other cogs that are dark blue in color, those are the care components of a highly functioning system of care. Think about these as specialty areas. You have population health, primary care, specialty care, hospital care, and post-acute care. The one thing that I want all of us to remember is that creating a high functioning system of care is a complex and expansive process. It requires different components to work in synchrony with each other. And because of the number of components that make up the system, it is expansive. It requires a lot of resources to be stood up. So if we move to the next slide, this slide is focused on some of the key findings from our first phase of work. So when we started our work at Central Health, we quickly realized that the population that Central Health takes care of is unique. So it's unique in its demographic profile. It's also unique in its clinical and epidemiological profile. Now, what that meant for us was that the outcome of our work would have to be tailored to meet the unique needs of our population. So we started analyzing the needs that existed within the population. And the way we did that was through a three-pronged approach. The first thing we did was we looked at the data that we received. The second thing was we talked to stakeholders up and down the chain. We talked to leaders at Central Health. We talked to leaders at our partner organizations. But we also paid special attention to the patients. We really wanted to hear what they were seeing, what they were feeling, and what they were experiencing when they interacted with the system. And these three things formed the core of our analytic approach. Now, the key findings that came out of that analysis are what you see on your screen right now. All of us know that our population is extremely diverse. And what that means is that the system of care that would be required to meet their needs has to be tailor-made to make sure that their needs are actually being met. So what I mean when I say tailor-made is it has to meet their clinical needs, it has to meet their social needs, and it has to be culturally competent. We centered our analysis on this idea of culturally competent care, not only at the strategic level, but also at the clinical level. The second thing that we found out was that because of the nature of the healthcare environment in Travis County, we are dependent on a lot of providers to provide care to our patients. That's good and that is bad as well. So you don't need to be overly reliant on other partners because it impedes flexibility. The third thing that we realized was that if we started looking at the different modalities of care, the need for primary care is significant. A lot of our patients don't get access to primary care on time. And when we think about the future, we have to keep that in mind. That need also exists in the specialty care arena. Across medical and surgical specialties, we saw that the capacity of the system was not enough to meet the needs of the population in Travis County. Now, this idea of system of care, again, is based on different components working together, like I stated. Now, for central health that depends on different partners to provide care, it's extremely important for data to be shared openly and in a timely manner across the system so that the left hand knows what the right hand is doing and that accountability is set. And there were some challenges around data sharing as well as staffing when we thought about the system of care that is front and center to what Central Health does. The last thing that we found out was because we are reliant on partners, we need to consider direct services as a key area for us to focus on. We need to think about how we can make sure that access to care is timely. And in order to do that outside of the partners that we work with, thinking about direct services and direct care is a key criteria for us to consider as we move forward. Next slide, please. So the phase of work that we are engaged in right now is phase 2. Now, there was a phase 1, which was concluded about 6 months ago. And phase 1 of our work was focused on what Central Health needs to do. And what came out of that work was a strategic plan that was adopted by Central Health. Now, when we thought about what Central Health would do, there were 2 things that went into it. The first one was understanding needs in the community. And the second was understanding what core competencies and capabilities were available to meet that need. Now, if you think about it, it's essentially a demand-supply equation. What is needed in the community is the demand, and our capabilities and competencies are the solution. And what we found out was there was a mismatch in the demand and supply. Now, the question that was in front of us was, how do we make sure that that gap is reduced? And what you see on this slide is the what. So what do we as Central Health need to do in order to close that gap? There are 4 key strategic imperatives that Central Health has to focus on in order to close that gap. The first one is access and capacity. There is limited capacity, which impacts timely access. So when we think about what we need to do, we need to build capacity so that access is improved. If we come up to a point where capacity cannot be built, we need to think about how we can use existing capacity in a more efficient way so that we are still improving access. The second thing that we need to focus on is care coordination. So because of our dependence on partners, because of the fact that if you think about the patient journey, a patient goes from a primary care clinic to a specialty care clinic to maybe an inpatient clinic and then to post-acute, there are multiple transitions in care. And people, our patients, are falling through the cracks. And in order for us to make sure that they are continually engaging with the system, we need to focus on care coordination so that once a patient is out of a primary care setting, once a patient is out of the primary care setting, they have a care coordinator assigned to them so that they can walk them through the system and be there for them if they have questions or if they're facing issues accessing the system. The third thing was member engagement. Now, we have used social determinants of health and health equity as a cornerstone of our recommendations. And coming out of that was this idea of member engagement being the third pillar of Central Health strategy. Now, we know that our population is diverse. We know that they live in geographic areas that are all over Travis County. Now, what that mandates is that we need to engage our members in a personalized, tailored way. So culturally competent care was an idea that we continually use to think about what we need to do. We also need to think about engagement. So in order to engage patients, we need to educate them. So education would drive engagement, and then engagement would drive how they interact with the system. And we want to make sure that they are continually interacting with the system so that they know what care is available to them, and then they can later on access that care as needed. The fourth pillar of our strategy was the system of care idea. We know that as of now, we are reliant on our partners. And we also know that continuing forward, we will have to rely on our partners for things that make sense. And in order to do that, we need to think of care delivery not in terms of silos, with one silo being owned by Central Health. We need to think about care delivery as Central Health being the system of care that addresses patients as their needs progress along the continuum of care. Now, the second aspect of the was, what do we actually need in order to do what we need to do? So if you look at the box that's to your right, it lists some of the key areas that need to be built up in order to meet community needs. The first one is clinical staff. Clinical staff shortage is something that every provider system in the country is dealing with, but the impact of these deficiencies is higher on us because of the acuity of our patients and where we are in meeting their current needs. Number two was administrative staff. So engagement, eligibility, enrollment, scheduling. We need staff that enables us to do those things because we want to bring more patients into the system. And then we also need patients to have somebody to go to if they have questions as they're engaging with us. The third thing was IT and system capabilities. Things like triage, where a patient comes in, you assess them clinically, and you route them to the right point of care, is something that is necessary. And the necessity of a system like that is magnified by the fact that clinical staff, we don't have enough clinical staff. In order to optimize existing capacity, we need to make sure that the right patients are going to the right provider. The fourth one is data management capabilities. Like I mentioned, for a system of care to function appropriately, data sharing has to be appropriate and timely. And as we think about Central Health taking on more patients, we need to make sure that we have a system that identifies those patients, checks and assesses the acuity and clinical needs of those patients, and then routes those patients to the right point of care. And for that, data sharing and data management capabilities are necessary. Number 5 was contracts and agreements. Contracts and agreements should ideally be designed so that every party involved in that contract is getting the most out of it in terms of value. Now, value for Central Health is access, quality, and capacity. And in order to do that, we know that we have to leverage contracts and agreements to move the needle in the right direction. The sixth one was fiscal capacity. As you've seen, there's a lot that needs to be done. And in order to do things efficiently, we cannot try and be everything to everybody. We will have to prioritize areas, and that has to be driven by data, and that has to be community-centric. Now, prioritization is at the heart of fiscal capacity because we will have to spend our money in a way that drives value the most. The last one is infrastructure. So physical capacity is required to meet the evolving needs of our community. So with the RZ Clinic, Hancock, there is movement in the right direction, but if you look into the future, we'll have to think about building infrastructure as and when needed as well. Next slide, please. Now in this slide, you see this red star in the middle. This is where we are right now. So in our last phase, we developed a strategic plan. We identified what needs to be done and what is needed for those things to be done. In this phase of work, our first charge was to look at the community needs and then start prioritizing those needs to see where we go first. Now, what would come after this would be a list of community needs, and then based on where needs are the most, we would then have to identify capabilities that are needed for those needs to be met. Right at the end, that would translate to how do we actually build the system that's required, and what are the financials of building that system. So the expenses that would go into building and sustaining that system would be what comes right at the end of this engagement. Next slide, please. Now, as I mentioned, we are at a point where we have a list of prioritized community needs. So I know there's a lot on this slide, but just to orient everybody, right at the top, you have 3 boxes. Now, these boxes are indicative of clinical areas of need. So we have primary care, specialty care, hospital, and post-acute care. The bullets that are within these boxes are the specifics of what the need actually is. So for primary care, healthcare for the homeless is in there. Expanding access to same-day care is one of the needs. And then expanding access to primary care, including preventative care, is another need that is in this bucket. In the middle, we have foundational enablers. So we try to differentiate core clinical capabilities from capabilities that are more supportive in nature. So when you think about foundational enablers, these are things that need to be built, and these things are agnostic of which specialty area is being addressed through them. So care coordination, it impacts primary care, specialty care, hospital care. If you go down this list, each of these is a foundational element that would touch upon the buckets that are at the top, and all of these things are prerequisites for an efficient system to be set up and operated. Right at the bottom, we have non-clinical areas that need to be built or that need to be bolstered in the future. The first thing that you have here is coverage program and benefits and structures. So one of the things that we are focusing on is the enrollment period and whether the current enrollment period is right or not, and whether we should extend it. The nature of benefits is something that needs to be considered as well. The last thing that is on this slide is social determinants of health. Like I mentioned, our population is extremely unique, and we need to be aware of the clinical, the cultural, and the epidemiological profile of our population. And a lot of that is being driven by our understanding of different social determinants of health, because this allows us to translate theory into numbers, and those numbers are then driving how we prioritize needs and what capabilities would be required and in what sequence. Again, just wanted to give you an overview of the needs that we've been able to prioritize till date. We are continuing to work with Central Health leadership to dive deeper into the details of the nature, scope, scale of these needs, and that is what would come next. I want to take a pause there. After this, we move to the question and the discussion section, but any questions or any thoughts?
Any questions? Manager Mitsai.
I have a question.
Oh,
It's Shannon.
Shannon, you have a question?
Yeah, I guess a quick question. Where does public health dovetail with your profile here? Because you have social determinants of health and you have primary care and specialty care. There's some interplay between those. Can you speak a little bit to that?
Sorry, I didn't track the question. It was hard to hear.
Where does public health dovetail with what you just presented?
Oh, so public health, we talked about models of care. So the idea of models of care is going to allow us to use public health related principles to see how these different boxes at the top come together. So the idea that we want to focus on now is the patient journey and how that patient journey will impact how and where these capabilities get built. And if you think about the patient journey, what drives that patient journey is the concept of public health. So looking at the population, their profile, and using that data to identify where in the patient journey the needs are the most and how we go ahead and address those needs in a prioritized and efficient way. Does that answer your question?
Kind of, sort of, but I'll leave it at that. I appreciate it very much for your explaining that.
Thank you.
Go ahead.
For that presentation. Just really quickly, I know the purpose of this exercise today is for us to, because focus on which priority we want to work on. Like, I'm just confused because like the list of these priorities are huge and what can be achieved. So how are you going to be able to refine those priorities? That's fun.
Yep, so that's a great question. We want this to be a data-driven approach. So what we are doing now is we are looking at claims data. We are looking at utilization data, both from within the system and outside the system, to see where the magnitude of the need is the most. And when I say where, it's three things. The first one is the demographic profile of that population. The second is the geographic location of that population. And the third is the clinical need of that population. So we'll triangulate these three to come out of this exercise with where the need is the most. And then the other aspect is connecting that and juxtaposing that on our financial capacity. So we might find out, and I'm making this up, that creating a level 3 trauma center is what we need, but we don't have the money to do that. And doing that would take time. So there's this whole financial and temporal nature to that as well. So again, to answer your question, the scale and scope of needs and our fiscal capacity and the temporal nature of our initiatives would allow us to prioritize where we go first.
Thank you, Manager Valadez.
My question is, maybe I'm trying to figure it all out. So we're dealing with a system change, a complete system overhaul. I get that. And what I want to know is, when do we talk to or address the financial needs of the services that are needed for those that are coming in and out of our MAP population or CHAP population or whatever, and those that are the chronic condition, they're going to permanent residents in that world. And I'm talking about OT, PT, therapy, equipment, rehabilitation, blah, 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 that whole other world of people who are coming in and out for some, and who are going to remain there for others that don't have insurance, or we get them on CHAP, depending on what their significant need is, and how that is addressed in our long-range financial need. This is how many people, because it's expensive. Okay, and when you're talking about a huge population and we only have finite dollars available, how is that determination going to be made as to who gets what, when, how, and where?
So to answer your question, when we think about, so there are two aspects to it. The first one is how big is the need? And the second is what's required to meet that need. So in order to get to how big is this need, we are using two data variables. The first one is the type of service, which to your point would be OT, PT, and the second is the volume of patients. So by understanding those two at the specialty level, we would have a fairly good idea of what the demand is.
Well, what I'm saying is that I know that we can get that data from community care. They're the ones that are providing the services to our MAP patients and those contracted providers who are providing services to our MAP patients and CHAP patients. So what I'm talking about is, where is that dollar number going to come into play as to how long they're going to be eligible to access those services, and when do we realize, well, as more people are coming in and as our need is growing, especially as I look at my geriatric population, with a hip fall and, then I'm permanently disabled and blah, blah, blah. When does that come into play? Especially for those that are not eligible for Medicare, they're not eligible for Medicaid, and they have nowhere to go but Central Health and community care.
Yeah, so what I mentioned was the first part of that equation, right? So you need to know how big the need is. Now, the second part is the financial piece. So what we'll do there is we'll think about, we're actually doing this already, and we have.
Yeah, I figure you are.
We have the data. So what we are doing is we are looking at current enrolled and potential enrollees, and we are running analyses at those two levels. So for both of these buckets, we now have two data points. The first one is what the scale of that need is, which is essentially what services are required and by how many people. We are using that to then identify what FTE counts would be needed to support that, what the physical infrastructure would be if applicable, and then using those two variables to come up with the financials, right? So you need to hire one physician and you need to build a building. That translates to money. So that would be our starting point for both of these. Now, as we move into the future, we are forecasting what the in and out population would be. And we are building that into our financial models that would give us that buffer to dial up or down as and when we see that happen. Now, we are doing that again at a specialty level for different sets of population. We actually had a discussion with the CH leadership team 2 weeks ago where we went into the details of where are these patients coming from? Are they Medicare only? Are they Medicaid or Medicaid? For the justice involved, it's a special population. How do we account for the financial need for just that population as we look into the future? So it's a very detailed analysis.
For me, what I'm looking at first is I'm looking at our MAP population and our CHAP population. Medicare and Medicaid, they can access the services or the facilities that exist outside our system. Yep. What I have to prioritize is our targeted population. Right. Okay, yep. So that first. Yeah. And then if we have Medicare or Medicaid patients that are accessing services through Central Health, I'm assuming that's one of the reasons we were talking about when we were talking about an executive session last meeting, is a possibility of having to look at future need based on some of these things. But now that I'm living in that world, it's become much more acutely important for our patients, and seeing the issue in how the gap exists. There is no smooth transition. There is no bridging that gap. So I just want to make sure, we don't have to have this conversation right now. I just want to make sure that those things are being addressed as we look at overhauling this system.
If I may.
Yes.
You know, part of the deliverables of this operational and financial sustainability phase of the work is when we bring this back in the spring, is so that the board can start having those deliberations.
Okay.
Thank
you, Mr. Geeson. Mr. Motwani?
Thanks, Chair. I don't expect this to take too long. I was wondering if I might address Manager Jones and ask if his question around public health was if we are engaging or considering the City of Austin public health with respect to the SDOH strategy.
Manager Jones, did you hear that question?
Yes.
Okay. Well, if that is indeed what the question was, and I think I'm really interested in that too, just in as much as the non-duplicative, or how we could how we can leverage resources as much as possible in a 1 + 1 = 4 kind of way, and then particularly just given that many of us in the room are civically involved in entities that might be able to help bridge communications where it may not otherwise be, or at least bridge community mandate in a way that otherwise might not occur. I think it'd be interesting to sidebar that conversation or deep dive into it, however you may see fit. I'm happy to discuss that at a strategic planning meeting or with staff, but I would love to learn more about that particular segment of the strategy.
I totally agree. I don't think we're going to have time tonight.
Sure, for sure. Absolutely.
But I think we'll have other opportunities as they come back with additional information and our input to be able to have that discussion.
Thanks.
Thank you. Sure.
So I think the next section is a questions and discussion section.
Thank you, Abby. So we've been really looking forward to this portion of our presentation tonight to really kind of engage with you So the intent of this exercise is not to take a formal vote, but really to get your input and feedback as we go through this process, because it's so important to have your perspective as we advance this work. So what we're going to do is go through a polling exercise where we'll use the keypads and you'll be asked a question, and then the results will be shown on the screen after each question is answered. So you'll answer the question, the results will show. We'll go through the next question, the results will show. So it'll be very interactive, and you'll be able to see how your peers are also responding to the same question. And then we'll have some opportunity to dialogue around some of these domains. So are we ready to start with the polling exercise? Great. So in front of you, you will have your keypad. So A, it represents yes, and B represents a no answer. So for the first question is, oh, we have a question on how to turn it on.
A and B.
We're on. I'm on. I'm ready.
Lift off.
Yeah.
Okay, perfect. So the first question is at the very top of the screen, but really it's, is the current safety net healthcare system in Travis County sufficient to meet the healthcare needs of our safety net community? Yes is an A, B is a no.
How was I to, Monica, when you told me, how was I to interact?
Manager,
Just tell us. Tell us.
Yeah, if you want to, you could say yes or no, or we can do this just as part of the facilitated discussion that will happen after every question.
Okay, that's fine. Yeah, that'll be fine.
Okay, thank you, Manager Jones.
Okay, so we have 6 no's, okay? So next question, do you believe that we should continue to build on the existing healthcare system that exists in Travis County today? A is yes, or B is no? Okay. Last question under this domain. Do you believe that a complete restructuring of the Travis County healthcare delivery system should be explored to meet the healthcare needs of the safety net?
Travis County healthcare system? Is it just us or all the entire? That's not clear.
Well, we are responsible for the safety net healthcare system. That's us.
It's the system, the healthcare system that serves safety net population.
That's us. There isn't another one.
Okay, so we're split evenly. Do any of these surprise you?
No.
To be expected.
Manager Jones, can you see the screen and kind of how the responses have come in?
Microphone, please.
Manager Jones, are you able to see the results on the screen?
Yes, I am.
Great. And any additional comments from your perspective?
Well, I concur for the most part with what I see here in terms of those who believe it
Great,
should be
thank
built
you.
upon.
Thank you, Manager Jones. Okay, we can move on. Thank you.
Do we turn this off now?
No.
Oh, we got more questions.
We have more. Okay, so now this is slightly different questions. So when we think about our answers, it's not going to be a yes or a no. It's going to be based on a category. So your categories align with the A, B, C, and D. Primary care and wellness is A, specialty care is B, hospital care is C, and then D is post-acute. So question number 1, under this category, what do you consider to be the highest priority for Central Health?
You just have to pick A, B,
Yeah.
C, or D. You cannot, no, you can't have multiple answers.
I can see how they would follow.
Okay, and Manager Jones, can you see the results of this question?
Yes, I can.
Great, thank you. As an additional step to this question, in which of the above areas do you consider Central Health today to be the strongest? So same categories, A through D. That's 6. Okay, so unanimous for those on the phone, but primary care and wellness. Last question under this category. In which of the above areas do you believe Central Health should be the strongest in 5 years? Okay, so for those of you that are on the phone that cannot see, we have 4 in specialty care, 1 in primary, and 1 in post-acute. Manager Jones, did you have any other comments?
I would have been a little different than those, but I understand where they are, yes.
Thank you. For question number 3, so we're going to go back to a yes or no format. So yes is A, no is B. Does reliance on partners hinder Central Health's ability to meet the community needs of our safety net? Okay, so we have 4 yes, 2 no. Manager Jones, any feedback or input that you'd like to share?
Yes, I would vote yes.
Thank you. Okay, then we can move to the last question, please. Okay, so still a yes or no. Do you believe that the identification and prioritization of initiatives must be data-driven as we think about how to address the healthcare needs of the safety net? Okay. And Manager Jones?
Yes, yes.
Thank you. Okay, and that brings us to the end of our questions. So this has been incredibly helpful for our team because your perspective is so important as we advance this work, and we really are at a kind of a critical point in this engagement. If we jump to the next slide. You'll see where we are in this process. So right where we are is really kind of looking at what are those key priorities, and then what are the initiatives that will drive impact to our safety net community to really improve their health and wellness, and really expanding access to the critical healthcare services that they need. So we will use this information as we look at initiatives and help to go through that prioritization process. So in terms of next steps, we're going to finalize the catalog of those priorities, incorporating the feedback that we received from you tonight. We're going to develop impactful initiatives. So where can we have the most impact to drive change for the safety net so they have expanded access to healthcare services to help improve their outcomes? And then we will come back in January to provide the Strategic Planning Committee with an update on the work that's been completed over the next 4 weeks.
Okay. Thank you very much. I appreciate that. Any questions before we end this presentation? Manager Valadez?
Will we get the results prior to the meeting, or do we have to wait for the meeting to get the presentation? The reason I ask that, because if we know we're going to have a meeting at the end of January and you all are going to present the results to us, are you going to unveil them during the meeting, or can we actually get those a little bit in advance to review them and then be prepared for your presentation and have our concerns or questions written, or a time to submit?
So it's not done in January. It's
Okay.
just the next phase
next
in
step.
January. So just like we did before this meeting by sending the materials in advance so that you guys could be prepared and review them.
I want to thank you all for that.
Well, no. We are going to do that again in January, and then I think there are going to be January. We're going to be over here. And then we've got February, March, April. This is like a June thing. So we're going to be marching along. And yes, before June.
Thank you.
Yeah.
And members, again, I really want to thank you all for participating in this interactive exercise. Like they said, it helps to know where you are right now in terms of future work on this, so thank you.
And mostly on the same page.
Monica, Avi, Danielle, thank you very much. Appreciate it.
And thanks to everyone on the technical side. Everyone through meetings preparing and who ran all of this. So thank you.
Thank you. Thank you very much. And we look forward to the next session.
It would have been interesting to have our new member have participated in this. Just to let you all know.
Okay, agenda item number 4, receive an update and take appropriate action on the HAM Premium Assistance Program and other Sendero financial and contractual matters. Jeff Canodal will be presenting.
Good evening, board members. Jeff Knowle, Chief Financial Officer. I'm going to begin this presentation. Next slide, please. This presentation is a request to improve an increase of HAM members, Health Alliance for Austin Musicians, enrollment by 500 to Sendero Health Plans. Next slide. Central Health, this actual program is a long-standing partnership, a very successful partnership that we've had with HAM. The program itself, Central Health, subsidizes premiums for Sendero, Affordable Care Act, Silver Plan. The subsidy, as we're working through it this year, the average member premium subsidy is $221 a month. As the board will recollect, in our budget, we had a budget to enroll HAM members, and as of 12/12, we had 925 members enrolled. Just as a reminder, the enrollment period for the ACA runs through January 15th of 2023, and then there's a slight, we'll talk a little bit about a slight enrollment opportunity after that also. Next slide. So as I mentioned, this is a longstanding partnership that Central Health Sendero has had with HAM. And this is a chart that shows historical enrollment. And then with this request, what we project the enrollment will be related to 2023. Next slide. So this request anticipates elimination of the current wait list. There has been a wait list related to this program. The intent is to eliminate that list. As I mentioned just a short moment ago, there are some opportunities for us to enroll members past January 15th. There's a provision in ACA that allows enrollment at any point throughout the year if a potential member has a income level that's less than 150% of the federal poverty level. This request has an estimated premium cost of $1 million, and we're not asking for additional budget. We're utilizing existing Central healthcare delivery budget that exists in the fiscal year 2023 approved budget. Next steps, obviously completing enrollment. We're fairly far along in our current enrollment, but we have we'll need to spend the rest of this year enrollment period, assuming the request is approved, enrolling the subsequent members. Implementing enrollment procedures for post-enrollment period that's after January 15th. What does that look like? HAM has been a tremendous partner to us in this program, and we anticipate working closely with them to evaluate what's in the best interest of the patients and their members. And then last but certainly not least, as we move into the new year, just initiating and evaluating any additional or new partnership opportunities for both 2023 and 2024. So again, just evaluating any enrollment opportunities that may exist in the current ACA regulations for 2023, but really looking at new partnership opportunities as we begin our enrollment period for 2024. Again, this is on a calendar year, so we want to start thinking about that early. There's a lot of work on both the Central Health staff and any participating partners side of it that needs to be worked through. So with that, I will turn it back over and am available to answer any questions.
Thank you, Jeff. Appreciate that information. It's exciting that we are going to add individuals to Sendero. And I think that makes many members on this board pretty happy and excited. Any questions? Manager Montani?
Definitely appreciate this movement. I think it shows deference to both the mandate from within this board, particularly Manager Valdez, as well as from the Commissioners Court. And it's really great to see how quickly we are able to react. I think that's a really substantial number. Jeff had mentioned more partnership opportunities, and I know that Board Chair DeLargy is really keen, especially also in deference to the
the mandate from the Commissioners Court on seeing how we can expand coverage through, by any reasonable means. Is there anything in the pipeline, partnership-wise, that you can share, or
I
or
will
not?
share that we've had some discussions. I think the one aspect of it that Pam has been great about as far as managing the process, managing the membership. I was impressed just going out on their website. I mean, they are making a drive to get people enrolled, and there is a lot of intensity in that process. We have talked to a few entities. I'm not going to spill the beans on who they are, but I will say that we looked at a quick startup, and I think there was realization that this is really a lot of effort if we're going to do it correctly, that there's a lot of thought and effort that needs to go into it. And instead of doing something quickly and haphazardly, I think the consensus of both parties was, let's evaluate starting in 2023 and move forward in a real thoughtful and diligent process. So I'm looking forward to bringing other opportunities both to the Sendero Board and the Central Health Board in the future.
So it sounds like you are cooking things in the pipeline.
Surely trying to, yes.
Thanks.
Thank you. Manager Valadez?
I move that the board approve increasing the Sendero Health Plan's ACA subsidy amounts for fiscal year 2023 as presented by staff.
I have a motion by Manager Valadez. I have a second by Manager Musaiti. Any further discussion or questions? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously. Thank you very much, Jeff. Appreciate it. Okay. For agenda items 4, 6, and 7, we will be going into closed session. So that? Yeah, there's a part of 4 that we've done in open. There will be a part of 4 that we will do in closed. Okay? So, it is Wednesday, December 14th at 8:08 p.m. I announce that the board is convening in closed session to discuss agenda item 4 under Texas Government Code Section 551.085, governing board of certain providers of healthcare services, and Texas Government Code Section 551.071, consultation with attorney, and agenda items 6 and 7 under Texas Government Code Section 551.071, consultation with attorney.
Dr. Bell,
Yes.
if you could read item 7, I don't know that.
Oh, I probably
The other
did
two
not.
you have read. 7.
Agenda item number 7, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Mike Giesland. Cause number D1-GN-17005824 in the 345th District Court of Travis County. All right. Okay, we are back in open session. It is December 14th at 9:07 p.m. On agenda item 4, receive updates and take appropriate action on the HAM Premium Assistance Program and other Sendero financial and contractual matters. I would like to move that we authorize the Central Health President and CEO to take necessary actions to secure and support agreements involving reinsurance or financing for Sendero Health Plans, Inc. The Central Health President and CEO will report any actions taken under this authority to the Central Health Board of Managers, parentheses board, via email and report the same at the next appropriate board committee or meeting of the board, whichever occurs sooner. The report to the board is in addition to other forms of communication to the general public and or government agencies. Do I have a second?
Second.
I have a second from Manager Valadez. Any further discussion? Hearing none, all in favor?
Aye.
Aye. Any opposed? Any abstaining? Motion carries. Okay, on agenda item number 3, we are going to have that report at our January meeting. We'll double up on the 2 months of financial statements since it's getting late in the hour. Lisa informed me that because it's early in the year, there's not a whole lot of activity that's going on financially. So there really isn't any imperative information that we need to provide you guys. And there's Lisa. I hope I paraphrased that okay. All right. So agenda item number 3 will be postponed. Do I need to read it, David? Okay. Agenda item 8, confirm the next regular board meeting time and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for next Wednesday, January 25th, 2023 at 5 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Manager Valadez. And Manager Musaitif, seconds. I have a motion by Manager Valadez. I have a second by Manager Musaitif. Any discussion? All in favor of adjournment? Aye. Any opposed? Motion carries. We are adjourned. Thank you, members. I appreciate it.
Happy holidays, everyone.
Happy holidays to everyone.